All right. Good morning, everybody. John Harris here, managing partner with Fortune Management. It is 8:03 on Wednesday. Thursday, April 30th, end of April. About to start May, the month that we get to go back to work and get back to the swing of things. I'm really excited. I've got Jill Abrocta with us again here today. If you guys joined us a week or so ago for an OSHA update, she provided some key information and some essential steps for making sure that we are in compliance with the new requirements, new regulations from an infection control standpoint, from a personal protection equipment standpoint. I know there's a lot of questions kind of hovering around about those two particular areas right now. And so Jill has prepared for us an update today. So some people I think are preparing or getting ready to start seeing patients tomorrow. I know at least some of my clients in Tennessee were, until we got the extension from the governor to postpone until the 6th. But even still, infection control is an extremely important component of us opening back up. And then personal protection equipment is an extremely important component of us opening back up. And so Jill's going to walk through what we need to know, what we need to do to make sure our practices are in compliance and prepared to open our doors for non-elective care, to make sure patients are safe, make sure our team feels safe, and we've got an overall just safe and healthful work environment. So Jill, good morning.
Good morning. Good morning. Thanks for having me again, John. This is always pretty fun.
Absolutely. Got great feedback about the last one.
Thank you.
I know we've got some people that are going to be joining this meeting that were also in the last meeting. We've also got some new people. And so this is being recorded. It will be available on our YouTube channel. So feel free to, jump on there and watch the video, or have your staff go in and watch the video to make sure that they're familiar with everything that's going on. And without further ado, Jill, I'm going to turn it over to you.
Wonderful. Okay. Good morning. Happy Friday. Wow. We're going to turn a corner this week, which is wonderful. And John, if you just give me the screen presenter mode, I think I can sneak into my slides. So we'll get started, right? So exciting, right? We turn another curve here. And let's see, we're going to get going. Now, every week seems to change a little bit as far as, what we're supposed to do, what we have to do, what's kind of top of mind. I think what's top of mind is infection control, employee safety, and really know that you do have to have a written plan before you go back to work. Are you seeing my slides okay, John?
Yes, ma'am.
Awesome. Perfect. So I'm a firm believer in just streamlining things and making things really simple. As we go through these slides today, as John pointed out, it's really good. I like dealing and speaking with doctors first, so that sometimes as we have discussion, maybe things that you're like, wow, I didn't even really think that I had to go down that road. It's always better to have kind of a good idea, a good overview of what's expected, and then to be able to pull employees in to let them know that you've done your homework and your due diligence. And then I have a resource page on our website. So if you look at dentalenhancements.com, anything we talk about today and more, much more, you're going to have a video that's dental office preparedness protocols. It's currently 27 minutes, beautiful for your team to watch before going back to work, and they should watch that. And then we have cool tools, signs so that you can control social distancing. That's required in every state. So keeping patients at a good distance and making sure that you have signage and keep them maybe waiting outside of your office if possible, not bringing guests in. And then a lot of great posters and diagrams for employees. Hand washing, how to don PPE, how to doff, how to take it on and off. So good review, maybe something a lot of us haven't looked at since we were in school. And all of our legal links we try to keep updated as well. So really know that that's your resource when we finish today if you're trying to kind of keep up on certain things. Hold on 1 second here. I want to make sure I have the right slide deck. Yeah, we do. I just changed that picture for y'all. Okay, so I'm Jill Abrocta, and truly, I'm a hygienist, so lots of years as a hygienist. This is my second ground zero. I'd say COVID was a ground zero, right? My first one was in 1989 in Florida. I was a hygienist practicing like 10 miles from that dentist who had AIDS, and he was presumed to be opening his bloodstream during dental injections. Consequently, 9 of his patients came ill with the AIDS virus, and that put me in a kind of particularly interesting spot as I was running a study group for 30 doctors on OSHA. So I was able to work closely with CDC and met one of my mentors. Dr. John Molinari was a director at CDC at the time. You guys might know him as the godfather of infection control. So I sort of fell in love with the idea of making OSHA easy, simple, streamlined, because we have to focus on patient care, right? So it's kind of an add-on, sometimes a nuisance, sometimes overwhelming. And then over the years, I've developed our OSHA Made Easy and HIPAA Made Easy brand of compliance solutions. So I'm the founder of Dental Enhancements, been working in providing OSHA and HIPAA solutions to dental offices throughout the country for over a decade. And I'm really happy to kind of just guide you through what COVID brings to the table now. So today, we'll be looking at uh, clarification on dental office safety, seeing COVID, the risk classifications for dental offices. I'll spend a lot of time on the do's and the don'ts. Always go back to our website, the Dental Enhancements website, and there's everything that I'm going to talk about today and more. And I will stop like every 10 minutes for questions. We'll talk about the 3 most important things to get together before you start seeing patients. So there's some must-dos, and then solutions for how you can best prepare. The risk classifications, you will be in an aerosol environment. Now, hygienists are trying to cut down on aerosols by hand scaling. A lot of creative, good ideas, pre-rinsing with anything that's antiviral, the best antiviral rinses. I will have a slide on this a little later as well. 1.5% hydrogen peroxide. And John, you had mentioned one as well. That's by Dental Select, so that's a great one. But lots of things, lots of nuances that will make dentistry less aerosol exposure. So dentists, hygienists, dental assistants are in that highest risk group. Medium risk is to administrative team that are exposed to people 6 feet away. Please make sure, we'll talk a lot about the PPE to wear in the back for clinical care. Right? We're going to talk about N95s versus traditional PPE, like wearing a level 3 mask, eyewear that has side protection. That's what OSHA and health department inspectors will look for, and then full face visor. So that's for in the back as an alternative to the N95s. Your front office personnel, um, level 2 masks, gloves, and lab coat. That's going to be their PPE, and definitely making sure they're protected. The lowest risk group is what we're doing now, right? It's what my team and I do as we work. We work remotely all the time, and we do teaching remotely for dental offices. So to get trained, to get all the books and the bits and the pieces. So working from home is always the lowest risk, but we have to figure out what to do as we move forward. So 3 areas of compliance that every practice owner must make sure you have a really good understanding and a really good footing. And what I mean is, you know what you're going to do. You have a written plan before going back to work. So employee safety is key. If your employees aren't safe, they're not going to be able to feel safe in giving patient care safely. So retraining on OSHA, making sure you understand all of the OSHA protocols right now, and training on COVID management. Please go to our website. I will keep that free 27-minute COVID preparedness video up, and we'll keep that up. And then I'm going to sort of have to, at some point, change that landing page. It'll always be useful, but take advantage of that that 27-minute video for employees. I haven't had one employee who was furloughed say, no, I'm not going to watch that. They have to watch something before they go back to work. You have to have access to some kind of OSHA training as well. And that puts the pieces in place that employee safety, you've done your due diligence. Making sure that you choose properly the PPE. Are you going down the route of N95 masks, or are you going to go down the route of traditional masks? Then we go into patient safety, making sure there's a pre-screening process that you know the questions to ask, the signs to look for. to evaluate for COVID. Chair-side evaluation process, again, once you have the patient escorted in, right, social distancing has to happen. Another exam, including temperature for patients, and then be sure to have a social distancing program in place, staggering patients, making sure they're not passing each other. I have a wonderful ADA step-by-step what you do before patients, during, and after. I'll show you that. It's an 8-page that I think is just so beautifully laid out. We'll look at that in a couple of slides. And then hypervigilance with your infection control. Lots and lots of standard precautions and lots of disinfecting and sterilizing properly. Then, once you kind of understand or you've been educated or enlightened on employee safety and patient safety, 2 written plans are required to go back to work for COVID. One is a contingency plan. What if this rebounds and happens again? What if we have another pandemic in the future? So having a written plan that deals with patients, employees, furlough, dealing with keeping costs down, deliveries, supplies. So that's a contingency plan. And then if anyone's not muted, can we just make sure we're on mute? Just going to make sure everyone has a chance to mute before we move forward. Perfect. Oh, I'm getting a little backlash there, but there we go. And then anyone who isn't muted.
Hey, Jill, if you go into the participants icon down at the bottom, you can mute everybody.
I can mute everyone. Let's see. I'm going to learn something every day. So I'm seeing, yeah, I think we're good now. I think we're good. Perfect. Thanks, John. I'm getting better at Zoom. The next written plan is a respiratory preparedness plan. You must have written down what you chose for your PPE. Was it N95? A lot more preparation for N95 masks. So the preparation is really a big investment and a big investment of time for N95s. For the traditional, you still have to have a written plan to say, this is what we're going to go with. I've retrained and trained my employees, and that you have that in writing. This plan, these contingency plans and the respiratory preparedness is the first thing any OSHA inspector or health department inspector will look for upon return to work. Those are your 3 components. That gets you ready for complete compliance, ready to go back into practice. So keep that in mind. Super important, those 3 components. So this is that guide that I was talking about. This is the ADA's interim guidance on minimizing the risk of COVID transmission. So 8 pages, and it's before, during, and after patient care. So let's take a look at, I'm going to try to mute. Here we go. I'm going to mute someone who had, I'm learning this stuff, John, so that's great. Okay, let's take a look at this document. I will unravel it, just the high points that I pulled from it, but I think if any dentist can pull up this ADA interim guide for minimizing the risk of COVID transmission. It was written on April 1st. There are a couple of nuances that I'll fill in the blanks to, but this is such a great streamlined setup for you. This is actually the first 8 pages of our pandemic preparedness plan. So we do have an all-in-one solution that's a written template, but I start out with this because the ADA did it really well. So before going back to work, you have to make sure you have social distancing thought out and planned out. Use of signs and having patients and their accompanying visitors wait outside of the office if possible. You'll see on our web link, the Dental Enhancements web link for COVID, we have signs that you can print that says, hey, stay in your vehicle. So, well, give us a call when you get here on your cell phone. We're going to do a pre-screening again and just give you instructions of when to come in, right? So figuring out the social distancing. I love this one. Limit the items in your reception room. So remove magazines and toys, anything when a patient is in the office, touch less. So there's less contamination or spreading of germs. Stagger your appointments. So minimize the patient interaction within the office. And This was an interesting one. Now, there's a test available. It's called an IgG-IgM. It's a needle stick, right? A little pinprick, and then you do a sample if you're positive or negative for immunity to COVID. So those people who have positive immunity become the preferred personnel. They can't get sick. ADA also spells out that pregnant personnel or people who are over the age of 60 would go away from frontline for clinical. So these type of personnel are preferred if they have COVID positive immunity, and then have those written plans. I can't stress enough your contingency plan and the respiratory protection plan. Next, during care, standard precautions, hypervigilance with infection control, isolate suspected COVID patients. So many states, you're going to be governed by your governor. So the governor's word will fall into place with the CDC and OSHA, and that will fall into place with ADA. So isolating COVID positive suspect. You may have a patient that seems great through their screening, but you get them in the office, and what if they have a temperature, right? So being able to isolate and have them move to another area or even off to emergency care. Is there a question?
Yeah.
Question? No, just a little bit more chatter there. And then choosing the PPE. We do have to have either plan A, which is your N95s as dictated by ADA. Plan B would be using traditional level 3 mask, protective eyewear, and a face shield. And face C, or plan number C is no face shield. So hold on here. Hold on, I'm gonna mute there. There we go. All right. PPE, making sure that we don everything properly, put on the PPE properly, and take off properly. A lot of us haven't even thought about this since school. So I have a beautiful poster, and that was with permission from Cornell University. So it has both of them side by side diagrams. You may want to go onto our website for that. And knowing the referral process. If someone is suspect, either an employee or a patient of being COVID positive, you must work with your health department. Now, inside of our pandemic preparedness plan, not only are those 2 required reports in template form, but we have all of the forms that you'll ever need. Certainly the form for the referral for the health department, so you don't have to go and search that out. After patient care, I think ADA did a beautiful job. We know we're going to clean up with standard precautions, but change clothes before leaving the office. Bring an extra pair of street clothes, maybe in a Ziploc baggie. If you can possibly wash laundry on site, that's the best. If you take laundry home, again, take it home in a Ziploc, wash it immediately separate from other family laundry, and immediately take a shower. So these are the bullet points from this ADA's interim guidance. This one, I think, is the most logical and methodical for a doctor to go through. So really some good information. Now, there are 3 different algorithms that the ADA has, 3 different algorithms. And these algorithms are inside of our emergency guidance from ADA. But the algorithm for determining what kind of PPE, what kind of headgear should you be wearing? So as I was mentioning, A would be for wearing the N95. B, I think, is a really good choice. That gives you your traditional level 3 mask, the eyewear with side protection, and the face shield. In option C, you just take away the face shield, but I think that's taking away a lot of protection, right? So let's look at how this kind of rolls out. Choosing your headgear wisely. This is a requirement before you go back to work. By the way, if you don't have your PPE, you're not allowed to have employees work. So having the proper amount of stock and ration, super important, very important before starting work. So option A, this is dictated from the ADA, having an N95 mask, the eyewear with the side shields, and then a face shield. Option B would go with traditional level 3 surgical masks, the eyewear with side shields and a face shield. And then option C would just take away that face shield, right? Traditional mask and then the eyewear. before going back into practice. These are considerations. Now, let's look at option A. For option A, there's a lot of prep work. You have to have that written respiratory protection plan, educate your employees, go back through OSHA, go through new COVID education, have a written signed document that says they were re-educated, right? They need to know how to wear, maintain, and dispose of the PPE. They need to know the pros and the cons, the benefits and the risk factors of both. The PPE has to be properly fitted in ample supply. Now, for an N95, that employee has to volunteer that they're going to wear an N95. So here's where it starts to get a little bit different. The N95, you have to have a voluntary disclaimer signed by the employee. They understand risks and benefits. Then you go through a manufacturer fit test. So there's a hood and some spray and a nebulizer, and you're trying to make sure the suction on the N95 mask fits properly. Each employee that volunteers, I'll show you a fit test shortly. That employee also, if they're wearing an N95 mask, has to do a quick fitting training. So every time they place one on, there's 3 steps they have to take to make sure that that suction and that seal is properly fit against their face. There are decontamination units. They look like a dry heat oven, right? They're not to be autoclaved. They're not to be put through dry heat, but it's a particular unit that you purchase so that you can decontaminate those masks. And then the negative reactions, if something happens chairside where they're starting to feel the side effects of wearing an N95, headache, shortness of breath, dizziness, tiredness, irritability, if they're feeling at all claustrophobic, that mask can also pinch and put a lot of pressure, even scarring on the face itself. You'll have to have a protocol. How is that employee to remove themselves? Who do they talk to in management to be able to just say, hey, I need to take a break and then reconsider wearing the N95? So the next 2, the medical questionnaire and the clearance, these are best practices. They're not always required with every N95 mask. When I speak to OSHA inspectors, and I've dialed in a lot of hours with OSHA inspectors in the last 4 weeks. I think I'm at about 120 hours of speaking and learning and discussing with OSHA inspectors throughout the country. They're saying if you have a good faith effort for your written plans and all of this, and if you do best practices, they're going to look upon that much more favorably, and it decreases a liability for a doctor as well. So not every N95 requires a medical exam and a medical clearance. But boy, is it a good idea before you put one of those masks on your valued employees to send them for a medical exam, to have a lung capacity test. They take with them a medical questionnaire that's private. So I'm putting those up, the good faith best practices, if you're going to choose option B, right? At this point, John, I want to know, is there any questions? Do you think anyone has any questions?
You can have a level 3. I think that's
one thing I would say, Jill, if you can go into, and guys, if you've got any questions, please drop those questions into the chat box. I'll be monitoring that so that we can get those questions to Jill and get them answered. And then Jill, if you would, open up the participant screen.
Yep. Mm-hmm.
Host. And there's an option down at the bottom. I think it says more. I think it's on the far right. You can click on that, and we've got some people that are chiming.
Unmuted. Yeah, I do hear that. Well, and I'm having a hard time seeing where that more is. I'm muting each person individually.
Okay, there should be, if you've got options, there should be a button here that you can click, and it'll allow you to mute people upon entry.
Yeah, I am. Unfortunately, I'm not seeing that more, but I do see each person. So maybe if everyone could mute, that would be awesome. I don't even know if people understand how to. I certainly don't, and I'm so sorry that I'm having a rough time. Oh, here it is, more. Okay, and then there's a drop down that says mute all participants. Is that what you said it said?
Yeah.
Share.
Or it says mute people on entry or something like that. Because we've got some people that are registering late and enter the meeting late. So everybody's muted. When new people come in, they're not muted.
I am so not seeing that, which is unfortunate. Remote control, I do see the more. Stop video, manage participants. Maybe it's under that, right? Mute all. How about that? And then am I going to mute you as well, or are you a?
I don't know if it'll mute me or not, but if it does, you can just unmute me.
Okay, perfect. How are you? Can you hear me, John? I will unmute John. So let me just find John here.
Good.
John?
Yes, so that's got everybody muted. So I did
Okay,
have
cool.
I did have
Yay.
one question
Sure.
real quick. So we've got a mastermind group going with a lot of our clients to kind of discuss best practices and what's being done in each location. One thing that we're looking at is what we call 20-20-20 hygiene, which essentially has the doctor's hygiene check take place towards the beginning of the appointment. And the question I've got is if the doctor does the hygiene check at the beginning of the appointment, would he need, and we're not using Cavitrons in hygiene, so there's no aerosol, would the doctor need to change PPE before going into a restorative appointment?
Yes. Yeah. So that's something that changed this week that they're real strict on. And as I said, in that 8 pages, what came out on the 27th is that they want all PPE to be fresh, because no matter what, we're dealing with saliva. So I have had some gloves have to be changed, and the mask. Definitely. Now there's some gray area around even changing your lab coat. So to have those longer gowns, the over gowns, maybe that's a good thing to have for the hygiene check. And then if you have either a cloth or a disposable regular lab coat, no. But even the lab coats, ADA put out on the 27th that they want one fresh one per patient. It's a lot of work, isn't it? So figuring out how you can don something over might be easier for your hygiene checks, but definitely they're not fooling around with PPE. We'll keep talking about that too. Any other questions right now, John?
So we do have to have disposable lab coats.
Well, you can launder on site. You actually have 3 choices. You can launder on site. If you're laundering on site, you're going to do a lot of laundering. They want a fresh cloth lab coat for every patient. If it's disposable, those disposables should be level 2 or 3 lab coats. Disposed of after each use. A lot of offices are doing the surgical long gown as well. So because there is aerosol, that's what the current stance is that it's one. Yeah, so either disposable or laundered. And launder on site. Shouldn't be taking laundry home because it's not clean laundry, right? It's contaminated laundry. So you would either launder on site, great time to put a plumbed stackable washer dryer in place. And if not, you can get a medical grade laundering service. Cool.
Okay.
Good. Onward. Oh, more questions. Sure.
I've got a couple in here. Because of the crisis, it's been said that the requirement of the fit test is waived because there's very limited access to testing. Is that correct?
That is a misconception. The initial fit test must be done. The annual fit test is waived. So next year, 1 year from now, initial fit tests must be done. It's just too hard to be wearing something that different from a normal surgical mask. So you have to test lung capacity. Every single one of these that are checked in option A, and I would say that it decreases a doctor's liability to have that medical exam and clearance. Make sure that that's something that your volunteer employees can wear. You have to volunteer and then have all that paperwork in place. So no, we want to make sure that the fit test is in place initially. If you change brands, that's the only time you have to refit test. They're waiving the next year fit test. Kind of weird.
Okay, and does that a fit test have to be done at a certified or approved center, or can it be done on site?
It can be done on site, and usually you'll have really great videos. Like I'll show you one today from 3M, and they give you some good guidance. Once you have your head wrapped around it a couple times, it won't be that difficult to do the fit test. It's just getting one, and then you'll have to assign a respiratory protection administrator. So someone who's going to do all that paperwork, set up the program, be the go-to person, not only for fit tests, but just in case employees are having reactions when wearing the N95. Great
Okay,
question.
good.
Mhm.
Questions are rolling in here. So guys, keep
Awesome.
the questions coming. This is the benefit of doing these things live is we've got live Q&A. So
Cool.
it's going to be much easier to get your questions answered right now while they're popping up and they're fresh than, try to email after the fact to get the answers that you're looking for.
Perfect.
Keep the questions coming in. Next question is, can we use a level 3 and then use a cloth mask to cover that and wash the cloth mask at the end of the day if we're using a face shield as well?
Very creative. And as a trainer and not a lawmaker, I'm going to answer just to what the ADA, CDC, and OSHA says. One disposable mask per patient. So I would say that's very creative, but I'm going to stay in my zone.
Okay.
In my zone.
Okay.
Mhm.
So with that, an extension of that question, I would ask, because this is a what's the word I'm looking for? Speculation
Mhm.
in conversations that I've been involved in. Does wearing a cloth mask or a level 2 or 3, because it's all about preservation of cost and PPE, right?
Sure.
So
Mhm.
does covering an N95 with a cloth mask or a surgical mask extend the shelf life of the N95 mask with or without a face shield?
I think that that is also a really creative way to preserve and cut costs, but I've never seen that ever in anything I've read from ADA, CDC, or OSHA. So the cloth mask was really created by the public for the public, right? It's better than nothing, right? And I think that they're even looking at layers and best materials to use. So I've read a lot about that. I would say that that's very creative, but if I was working with N95s, I certainly would still be going through your respiratory protection plan and using that decontamination unit. So it is probably a way to preserve, probably not the right answer for an OSHA inspector. So, you kind of have to do what you do in reality, but also make sure that you're coloring in between the lines for all of the actual rules.
Okay.
So,
Let me challenge the rule of law here real quick. Okay.
mhm.
Because the OSHA, the CDC, state board, state dental associations, ADA, all coined the phrase exercise professional judgment with the availability of PPE.
Mhm.
So would you say that those creative solutions would fall into that gray area, coined professional judgment? And if so, I think that would be pretty obvious. If so, how would you assess the level of liability there?
Well, I think there's a big level of liability because in the documents that you'll read, if you're going to take that 8-page document from the ADA and even the update to that, because that was on April 1, now we're looking at some new released documents on April 27th that are even clearer. They're saying 1 mask per patient. 1 mask per patient. I still have to talk to you guys about the surgical. So really it comes down to this. If you don't have PPE, then you shouldn't be going in full force to work. So the level and availability of PPE determines the amount of patients that can be seen at this time, and then lessens, really just completely alleviates the doctor's liability. The reason that I really like to do these kinds of sessions first with the doctors is so that you can leave this meeting and really think or sleep on it to go, wow, what kind of level of liability am I comfortable with? So coming back and having the right amount of PPE. The other things that will start to happen once we go back to work, you're going to have all of your employees' eyes on the owner, and then you're going to have all of the patient's eyes on the entire practice. So making right choices and reading these documents so that you're very clear. That's what I clearly have taken away from the documents is if you have the PPE, that's the level at which you can provide care.
Okay. And then an extension of the previous question regarding lab coats. I said that if a doctor, has on PPE and he's checking hygiene on the front of the appointment, he goes in, there's no Cavitron, no aerosol, is he required to change PPE before he goes into restorative appointment? Is the change of lab coat conditional upon the presence of aerosol? So in other words, if aerosol is not present, is the coat change still required?
Yeah, what I've read, it is conditional on the aerosol, and then the regular OSHA law is change it when it's visibly soiled. So that's probably an area where you can kind of zip through, right? As long as there's no aerosol. So
Okay, good. Okay, good. So in the previous example, let's say it's 8 a.m. Doctor hasn't seen any restorative patients, puts
mhm,
on fresh
mhm,
lab coat, fresh PPE,
mhm,
goes in to check 2 hygiene patients. That
mhm.
procedure hasn't started yet, only the medical history, oral cancer screening, that kind of stuff. Goes in and checks those two hygiene patients. He can walk directly over into a restorative office.
Right. No visibly soiled, no
Correct.
aerosol. Yeah. Yeah. So I like that. I see. You spelled that out a lot. Yeah. Cleaner. So yeah, I
Yeah, I
would say
wasn't very
that's
clear
cool.
on the first example. So good. That's exactly what we were looking
Hey, and I want to point out too that I did get a document from the ADA the other day that said they are really interested in doctors using it's either a 099 code or a 0199 for either PPE or infection control. So back in 1999, I think the average PPE, I'm sorry, the average infection control cost per patient was $10. So now we're going to have even more costs. So do research and consideration. If you're working with third-party insurers, you'll have to kind of check and see what's going on. But certainly, as we evolve in this new era of dentistry, there is more costs. We're having problems with availability, right? And being rationed with this PPE, which if we're being rationed, then that means that limits how much patient care we can actually provide. But please know that there will be changes set forth for either recognizing PPE fees or infection control. I've heard it called both. So, I mean, that's hopeful,
I want to
right?
circle, not to delay you too much here, but this is an important area. I want to circle back to a question. Uh, New question came in. What about the KN95? So are we better off to use KN95 since they are cheaper and are accepted as equivalent to N95? And we need to change between patients and more readily available.
KN95s have been known to be gray market. So they're from Korea or China. And so a lot of suppliers aren't carrying them because they have to take the onus of responsibility that they're NIOSH certified. So there's the problem is the big gray market is in a KN95. And the way that you know that it's absolutely gray market, an N95 would always have a head strap and then a strap for in back of your neck. It would never be ear looped. So that's one way that I know a KN95 is counterfeit. But that's the problem is that a lot of those are known to be counterfeit or made in Korea or China. So you have to use your discretion there.
Okay, good. Let's see here. Okay, so if there are no aerosols present, do any PPE need to be changed, or is it the same as the lab coat?
Well, it would be the same as standard precautions. So if you're touching something or something's contaminated, obviously you would take that same chain of infection control,
Right.
right? hmm
Okay. Okay. Good. And then back to the what was it? I can't remember the actual code. I want to say it's 9999.
hmm
It's like a unspecified adjunctive.
Right, right.
Uh,
hmm
so there is speculation right now. I know the ADA is lobbying right now to get some legislation passed that would require dental insurance companies to provide a reimbursement for that fee. Right now, to my understanding, the dental insurance companies are not reimbursing for it. Our recommendation to our clients on that is I'm seeing with my guys, the lowest I've seen for any of my practices is $5 per patient. And we're calling that either an advanced infection control fee or surcharge or a COVID-19 infection control surcharge. If you choose not to charge for that, that's okay. That's completely at your discretion. Be sure to have that listed on your walkout statement so the patient sees it for two reasons. A, they know that you're going above and beyond the call of duty to preserve the health and safety of that environment. And B, you just did them a favor by writing that fee off. So if you do charge it, I'm seeing anywhere in the range of $5 to $15. My personal opinion is I think that fee is very, very appropriate. And it's kind of, I think every practice is going to be a little bit different. Let's see here. Vivek says it's D $19.99. Okay.
Mm-hmm.
I think it's very, very appropriate. And I think you just have to use your judgment in your market and your patient demographic as to where your fee should fall. But it should be big enough to make a dent in the cost of PPE and additional infection control investments, but not so much that it's going to deter patients from wanting to receive care. So, just collaborate with your counterparts in the area and what other dentists in your market are doing, and just, try to stay in a competitive range.
Yeah, very well said. Very well put, John. I would agree. Yeah, and that's great. I thought that was 1999. Perfect. Awesome. Anything else, or should we continue talking about the other options?
Let's rock and roll.
Okay, let's do it. So we really went through N95, talked a little bit about KN95, lots of preparation, some expense, definitely written protocol, definitely understanding the pros and the cons. And remember, N95 is a voluntary kind of a choice for your employees, and you have to have some written protocols. For option B, wearing a traditional level 3 mask, eyewear always with side protection and a face shield. Pretty easy, right? We know how to wear that. We know the pros and the cons here. And that would also be written down in a respiratory protection plan. Fit is pretty easy. The ample supply is where you're going to balance whether you're how many patients you're able to see. The same for wearing a level 3 mask and the protective eyewear. The issue here is what happens if post-operatively that patient that you are seeing is determined to be COVID positive. So really the best thing about all that work to implement option A is that there's low risk if you don't have to isolate. But for level B and level C, they would recommend that that clinician then go into 14 days of quarantine. So that's sort of how this entire headgear shows up, right? So A, you do the most work and invest the most to go into an N95. B, I think, is a really great road to go down. And there is that moderate risk that if you do have COVID positive, you would be recommended to quarantine. So I hope that that slide gave some clarification. I do want to show you what a fit test actually is right now. So this is 3M's fit test, and these are what N95s look like. The fit test comes with that hood, 2 nebulizers, and 2 solutions. You can either get a sweet or a bitter solution. They do provide the bitter because some people are allergic to saccharin. The tester, the administrator of your respiratory program, would fill the nebulizer, and then as the employee wears the N95, you just spray that inside of that hood and you should taste nothing. There should be a proper seal. Now, the employee also needs to know how to do a quick fit test before every patient, and that's putting the band across the head flat. The same band goes around the neck flat under the ears. And then what they would do is breathe in and really create a good seal on that mask. So that's a little 101 on fit testing, and then making sure that the user can fit that before every use. What does the practice owner need to do before issuing an N95? Definitely understand the precautions and the risks. Definitely understand that this is voluntary, and a disclaimer has to be signed by those volunteer employees. The employee has to know how, then you move forward into your fit test. The employee knows how to don and put the mask on, put it off, know when it goes into decontamination, and then that written respiratory protection plan, that's required. Those are all the things required before issuing the N95. Best practices. Remember, OSHA inspectors and health department inspectors are looking for good faith. So employees, to make sure their lung capacity can handle an N95, it's a good idea to give them, OSHA has a respiratory questionnaire that's private, that remains private between the employee and their physician. You send them for a medical exam. So that would be best practices. Some N95s require this, others don't, but that would take the whole level of, not thinking forward and making sure that that volunteer employee has the best possible choices and chances of wearing that N95 successfully. So I hope that's helpful. Remember, there's traditional PPE, right? So algorithm B, the ADA said, the level 3 surgical mask, the protective eyewear with face shield, this is a great option. Afterwards, it becomes a moderate risk, and then there's a recommendation for self-quarantine. Do we have to go this route? Not yet, thank God, right? So choosing your PPE wisely and documenting that. Who chooses this? It's the doctor, of course. You have your mind on safety and cost, reliability, low risk, even availability, right? But the employees also have choice. So this is sort of a meeting of the minds. I always think it's important for doctors to absolutely know the overview, the 10 floor up view of everything, right? And then having your employees, as they get educated, revisiting OSHA training, and then making sure there's COVID training before you come into practice, then you can make the best choices. Some employees may go on N95 and some may not. From a voluntary standpoint, some may not be able to. So all of this needs to be written, right?
Hey, Jill, one
So,
last mass question.
sure.
And we'll then I'll leave you alone for a little bit and let you get through another stopping point. One of the things that's being speculated is, obviously ways to extend the shelf life of the N95. I've heard things like autoclaving. I've heard things like putting it in the oven for 15 minutes at 150 degrees. What, if anything, can be done to preserve the shelf life of an N95? I've also heard that it can be used like 5 times, but you've got to let it rest for 3 days, in between use. What are the
I think the best thing to do is from the manufacturer, follow manufacturer's directions. If you're ordering them from 3M, I've seen the package insert for 3M, and it's a quite extensive, really great training, and then links for videos. You can just go right on YouTube. But calling they have 1-800 like OSHA and the whole specification. So really following manufacturer's directions. I have never heard that. I did hear that the inventor of the N95 was going to come out of retirement to try to invent a mask that could be sterilizable. And then I think, John, and you and I have even shared some, I mean, I would call them memes, people making comments on Facebook or LinkedIn that is doable, but really it's following the manufacturer's guidelines. Look, this isn't just a slap on the wrist from OSHA or the health department. This is someone's lung capacity and someone that's near and dear to you, yourself, or even one of your employees. So to mitigate any liability risk, just look at that package insert once you get your N95. Do some pre-investigation. You can go online. You can find the exact model of your N95 and start reading through. And there's 800 numbers on there for help as well.
Yeah.
Cool. Anything else?
That's it. Wait, one more. Sorry. Let's see here. We have one admin person prepared to do screening before patients are taken back to the operatory, but she's pregnant. Now, this would be a good one. Could she wear an N95, or will we need to look at moving her to a backstage position?
Well, you'll see in the document that is released from the April 1 that I showed you, and the newer one, ADA's newer one, says that you want to make sure that the elderly and the pregnant are on backline, right? Anyone that has stronger lung capacity and test antibody positive would be your frontline people to be doing intake and patient care.
Perfect. Okay, so that's all the questions right now. We'll take a break. Continue to put your questions in here, and then when we get to another stopping point, we'll address all those at that time.
Cool.
Thanks, Jill.
So where did I get all this information? OSHA put out a great document. It's called 3990. So in here, it does include everything you need in your contingency plan and everything you need for your respiratory protection plan. This took me the better part of a month to get through, but you can create your own contingency plan, your own respiratory protection plan. If you want something that's a template, that's fill in the blank, paint by number. I love simplicity, and something that takes you logically and methodically through your contingency plan. Ours is a 63-page document, and it deals with your employee and patient protection, how to monitor for COVID, curbing monetary losses, managing your supplies, and then how to report patients. So it's everything that's in the 3990 and more. And then for the respiratory protection plan, definitely having someone who's the administrator, what you'll do in your practice to reduce aerosols, employee protection, and then if you're wearing N95, we have all of the disclaimers, agreements, medical questionnaires, and then training. So there's a 3-page training guide. That is $159. You can just go right on to dental enhancements, look for that little picture. That comes instantly in an email. It takes about 90 minutes to read. I did include the ADA's 8-page document that I love, right? That before, during, and after treatment. So if you read that first, you're going to get a really good idea of what's expected. And then you start filling in this PDF. You can either print it and just fill it in by hand, or you can use the fillable format of a PDF. This is the first thing an OSHA inspector or health department inspector will look for when they're in your office, along with your OSHA manual being up to date and employee forums and training and things like that. So that's really great as a reference. After we've talked a lot about employees, now patients are going to be coming into office. You know, they already either are okay with coming in or have their own amount of fears, but definitely they'll be looking at how offices are taking extra measures to protect them and employees, right, for infection control. So a huge focus will be on infection control. As I move forward through the do's, what we want to implement to make sure your office protocols are in good shape. In 2016, OSHA and the CDC came out with a new guidance, a new booklet, 13 new protocols, and it's called the Summary of Infection Prevention. I'll put up a picture. It's a great read during this break. You know, definitely you want to make sure you have these 13 new protocols that apply to standard precautions in dentistry. So what should the team do going back into work? Keep up on what our main organizations, CDC, OSHA, and ADA have to say. Things will be changing a lot, I would imagine, over the next 18 months. We know to wash hands. Did you know that damp hands spread 1,000 times more germs? So drying hands twice will be even better on your actual skin. Some of those barrier hand creams are great. Not using hand sanitizers as a substitute. This is OSHA's infection prevention guideline. I would Google search this, the Summary of Infection Prevention Practices for the Dental Setting. CDC was watching dentistry for a 10-year period, and they said, hey, dentistry is not really keeping up on a lot of these infection control measures that we think they should. So in 2016, they put out this 44-page document. It's free, it's in PDF format, and it will outline the 13 new protocols that all dental offices must have in place. Things like handling sharps, recapping practices, sterilizing handpieces after every use, and that applies to turbine and low-speed handpieces. Testing water quality regularly, shocking your water and documenting that. So these are very important protocols. Make sure you get a hold of that document. Wearing that PPE appropriately, 1 mask per patient, understanding your obligations for wearing N95. We talked a lot about the visors, the masks, and the eyewear, but going one step further and providing best practices for either hair covering, surgical gowns, washing on site would be preferred. Scrubs usually can go home, right? But in the COVID environment, if you can wash everything in office is best. If you can have a laundering service, or certainly use Ziplocs and containing contaminated clothing, and making sure your employees wash that separately as soon as they get home and shower. Biomedical waste. Now, when I was involved in that situation, the AIDS situation in South Florida back in 1989, bloodborne pathogens was born. This is when we first had the ruling set forth by CDC and OSHA to use red bags, right? So the law since 2008 is that you have to have a small red bag in every operatory. You fill it up, seal it, and walk it down the hall to the bigger biomedical waste container. So before COVID, we were to put saturated waste in the red bag. Now, going back into practice, best practices inside that little red bag that you keep in every operatory, right, is best practices. Get rid of your splattered waste after every patient. Put the saliva ejector, bibs, splattered gloves, everything that can go in that red bag, seal it, and walk it down the hall. You don't want the exposure. I would imagine that this ruling will be changing to splattered waste as we go through this COVID event. Confirm your patient's wellness. Don't treat sick people. Get those signs in your reception room, better yet outside, and have visitors wait outside if possible, as well as patients. And then once your team goes through and gets updated on COVID preparedness and OSHA, showcase your infection control. I think what John had mentioned about that 1999 code is you're actually telling the patient we're doing things extra, but talking about that, even bragging about that is a good thing and will make employees and patients feel safer and in a little bit of an elevated, enlightened state, right, as we go back. So some other considerations, these are only considerations. New age bioaerosol suction systems. This one has an arm over the patient and it does pull that aerosol. This one is a mobile unit by ADS, and as it pulls that aerosol, it works with a HEPA filter, and then right behind the HEPA filter is UV. These are available. They're not, they don't have a lot of research behind them or medical-based evidence, but a lot of doctors like them because they show that you're doing something extra. You have to do some extras to control aerosol. So that's part of your respiratory protection plan. Another more medically evidence-based option would be to use and install these innovative air purification panels. Now, these have been used in hospitals and nursing homes for years. They're a little less obtrusive, hidden, and they use a HEPA filter and then right behind a UV light. This one is by VitaShield, VIDASHIELD, VitaShield. And they're known to kill MRSA and C. diff in nursing homes and hospitals. So another consideration. And this helps us to close that aseptic chain, right? If we're doing all of the other things for asepsis, but leaving an open air channel, with these, they just kind of close off and make that a more complete cycle for infection control. These are new. These are microbe killing barrier foggers. They use a chemical, I believe it's some kind of a safe chemical, to kill the COVID. They're used in grocery stores, industrial, and they just have a spray fog that will kill the virus. So those are available as well. And something that's really mainstream that I think is gaining a lot of popularity are these all-in-one bite block aerosol isolation systems. This one is Dry Shield. They also have Isolite. You know, in the new document that came out from ADA on April 27th, it said that anytime you're using suction, you should try to go with high-speed suction. For the low speed, it said that you would have to have some kind of an insert so you stop the backflow. So talking with your hygienist and seeing if that backflow on your saliva ejector is something you'll implement or if they want to start to use these, but that's something that's super popular. And consideration for mouth rinse. So John, you had mentioned the one from Dental Select and making sure that there's some kind of research behind that these rinses would be antiviral. Did you want to tell the name of that one that you had mentioned the other day?
Sure. It's by Dr. Rich Downs is one of the founders with Dr. Bob Martino. The company is Dentist Select. The product is OraCare, and the chemical compound is oh shoot, activated chlorine dioxide. And so it's a dual container set, and basically what you do is you pour the two liquids, a small amount of the two liquids into a single container, and when the two liquids combine, they activate, the chlorine dioxide activates, and it forms a gas in the mouth when it's being rinsed or gargled. And the reason that that particular part of the process is important is because gases are much less dense, and they can go into crevices in the mouth. They can go interproximally. They can go places that liquids can't because their density is so much less. And therefore, they kill a larger percentage of viruses. It is antiviral. They kill larger percentages of, matter of fact, it's the only oral rinse on the market, to my knowledge, that is antiviral, that actually kills viruses, bacteria, VSCs, funguses, and it's in testing right now to determine its effectiveness against the coronavirus, against COVID-19. And so we should
Perfect.
have the results of that test either the latter part of this week or next week. So we're looking forward to that. But that is an infection control component that a lot of our practices are utilizing for obvious reasons.
And I did find one study online from the Journal of Clinical Medicine, and it was testing 1.5 hydrogen peroxide and then povidone. So definitely, that is just smart. That's infection control really coming to the forefront of your practice, and that is something that your hygienists, dental assistants can talk about your side, right? Your efforts to
Yeah.
control COVID.
Since
So
we're
we've
since we're on this subject, Jill, I've got we'll knock out a question, one of these
okay.
questions real quick, and then one of the questions I've got is: are you familiar with hypochlorous acid?
I am not.
That is, I'm not. I don't know the details of it. Reagan's much. I didn't. I haven't seen the full infection control video that Rich Downs did, but he's, as I mentioned earlier, he's one of the co-founders of OraCare. He's a brilliant scientist, I would call him, but very, very smart guy. And he's developed a whole office disinfection system that includes OraCare, but also highly leverages hypochlorous acid, which, if I'm not mistaken, I believe it's a naturally occurring compound in nature. Like, it's not a man-made compound, to my understanding, and it's very the acidity is very, very low, but its effectiveness on COVID is like through the roof. Like, it's the most effective compound on this virus that has been made available. And so I know Yolanda Mangrum, one of our Platinum Circle doctors and one of our Fortune franchisees over on the West Coast, multi-location owner, has done a lot of research on that particular compound, and has found, the research and studies to show how effective it is, and she's incorporated it over there. But I was curious if you'd heard about that, because it's a pretty powerful addition to any infection control.
Excellent. Yeah, I think we're going to start having some nice new things to consider, and definitely part of the respiratory protection plan is not just doing the PPE and the basics, but they want to see that doctors are elevating. So these are all great things. So we talked about a lot, what to do and the considerations. And now I want to talk about things not to do. All right. So we don't want to ignore updates. We want to exhibit pride and have your entire team take that COVID, any kind of COVID training. Ours is on the Dental Enhancements website, 27 minutes. Make sure your team gets unified. Revisit OSHA training. Don't miss your scheduled updates. Before going back to work, teams should be viewing COVID type training and OSHA type training. Don't take shortcuts with hand washing, PPE, infection control. Don't use PPE if it's disposable. Don't come to work sick or treat sick patients. It is the obligation of employers to report any COVID positive cases. You do that with a patient through the health department. In the back of our pandemic protection plan, we have the actual form for all health departments. For reporting employees, we use form 300-300A. This comes with our OSHA manual, and you would want to make sure that Employees are self-monitoring their symptoms. Now employers can take the temperature of employees. At the beginning of all this, they couldn't. They started to implement that in hospitals, and it was really helpful. So a lot of the privacy laws, the HIPAA privacy and the American Disabilities Act, they really soften during COVID and during a pandemic situation. Very important to take patients' temperatures, right? That could really create a situation where you're either going to treat or not treat the patient. What does OSHA say to do in this situation? They say do what we've always said: wear PPE properly, definitely proper fitting PPE, eyewear with side shields, properly fitting gloves, puncture-proof utility gloves for soiled instruments. Each person who handles soiled instruments need to have one pair. I know that inspectors, they count the number of puncture-proof utility gloves. One mask per patient, properly fitting lab coat, preferably laundered on site or disposable, right? The dentist, practice owner has the obligation to provide a hazard-free workplace free of serious harm. That's why it's not just deciding on this PPE, it's making written plans. Here it is again, the summary of infection prevention for dental practices. So really topping off and making top of mind these new infection control practices. There's 13 new protocols for the dental office that have been updated. OSHA wants you to go by the strictest of your protocols. So if your state OSHA is stricter than the federal, you want to go by that. And then making sure that employees are safe in a chemical environment, using chemicals in the environment. 2 years ago, the US joined international efforts, and you have an obligation to be certified in something called Global Harmonization System. Every employee has to go through this class once. It is a separate OSHA module called GHS, or Global Harmonization System, and it talks about how you obtain and store new standardized safety data sheets that are the same throughout the world in 63 countries, and then how to read these new symbols for chemical hazards called, they're called pictograms. So those are OSHA standards that have been tried and true. This is how you go to our one hub to get all of this information from the Dental Enhancements website. Our second tab on that hub will give you the video link, all of these posters. We've updated since what I have you scrolling through here. And I just want to go out of this presentation for just a moment. Then I'm going to come back in and let's just go through and look at the website if I can go to that quickly. I don't know if I'm going to, let's see here. We can get you onto the website because it really is very beneficial if you want to take a glance at that. So let me know when you can see my screen again. Give me 1 second here. Okay, you guys seeing that? Yes?
Yes, we can see it.
Awesome. So here, the second tab will be the COVID tab. Not the very first pink sign. The second pink sign here, this is the 27-minute video, and we just updated that yesterday. You'll be able to get that pandemic protection plan. If you want something more comprehensive for OSHA, COVID, and HIPAA, I'll tell you about our offering there. This is where you'll find that 8-page document. Right at the top is that ADA as states open. So that's a really great document to follow. As you go through, you'll see your signs. I love this document. This is how you place and remove all of your PPE. And then as you go down lower, we have hand washing signs, cover your cough, and some of the ADA created how to determine what masks you'll wear. This is great. This is a generic back to work prep list, and it will tell you, hey, what do I want to do in order for headgear, for required containers, for aerosol containment. So all of these are really great tools, links that are updated in that free video. So I hope you guys will go there and visit often and make sure that that becomes something that will be, you know, helpful for yourself and your team. So now I'm going back into slides. We'll finish up here in the last 10 minutes. Are you back on my slides, John?
Yes, ma'am.
Awesome. What else is required? So For every single year, all employees have to go through an annual OSHA training. That's just a given, right? Clinical and non-clinical. Make sure before return to work, you revisit your training. Global Harmonization System certification, definitely once in a lifetime. And HIPAA laws, privacy and security of patient information, right? They become a little bit laxed, a little softened with teledentistry, but those are still enforced. And then definitely COVID management, infection control. Um, Being comprehensive with your programs is really key. We know there's 3 or 4, depending on your state, requirements. All employees have to be trained in all 3 of those if we're listening for Fortune attendees that are here today. There's about 1,000 pieces of paper that an OSHA inspector wants as soon as they come to your office. Within 5 minutes, you must show them your OSHA manual, that respiratory protection plan, the written plan, and the contingency plan for COVID, all of your employee training forms, vaccination forms, and occupational hazard forms, and SDS sheets. And then after they look at paperwork, if it's not in order, they really want to get into the office, examine the paperwork, make sure that you understand what you're doing. Then they tend to leave if everything looks good. If not, they'll start looking at 200 protocols that should be implemented. So you see, there's really like 9 components when you compare the 3 requirements, multiply that by training, paperwork, and facility protocols. This stuff can be intense, right? It can be really heavy, insidious, overwhelming. So if you're looking to create a new program, this stuff doesn't go away. It's not easy to look. We have, we have so many other things to look at going back to work. The average OSHA fine in 2020 was $13,000 per serious fine. Not rectifying it, not being willful to rectify doesn't make it double, it goes up 10 times. Being proactive, it takes maybe 12 hours of work to get all of your OSHA and all of your HIPAA back up to date. So if you do want a more robust solution, this is how our solutions work. The OSHA Made Easy and HIPAA Made Easy. We try to do this so that it's easy to understand, easy to implement, approachable. I do have trainers across the country that are former dental professionals. So OSHA experts, so former dental assistants or hygienists turned into OSHA and HIPAA experts. And really working with our team, it can help you to kind of just get this stuff completed. So our programs do provide manuals. The manuals are customizable. They're turnkey, but you customize them. Inspectors want these customized. So our manuals, I think there's 100 pages that we customize with you. We'll provide ready to use forms. No one wants to buy a kit and then you have to sit there and either write your own manual or create forms. Now we do our training through anytime webinars. So that's a great way to onboard employees as they are either not in the office, in the office. Our most popular is our private coaching. We do the coaching with one person in your office, hopefully you, the doctor, or your key contact people. And then after you'd go through all that video training, the webinar training, you'll get a customized report so that you can use that as a checklist to get the protocols in place. We don't create our programs alone. We definitely work with OSHA inspectors, lawmakers, and we have a legal team. So as we're creating templates and manuals and forms, it's double checked for us. The difference is we are providing these comprehensive programs. You do have access to a dental OSHA and HIPAA expert, and then we always schedule you. If you're doing your training in April this year, just get rescheduled for next year so you never have to worry. And we have a really wonderful Infinity program that gives you everything, all the components every single time so you don't go out of compliance. So if you're wondering, wow, when's the last time I really looked at everything OSHA and HIPAA, we do have a more robust program. A lot of offices are doing this before work. OSHA and COVID is required to have a review of that before work. Make sure your manuals are updated and all your required forms. Our all-in-one deluxe self-study gives you that 2-hour video, and then you get 2.5 hours with one of our experts. We'll send you a big box of books. You go through the manuals, the forms, And normally that's $19.98. For Fortune members, it's a reduction of 22% savings at $15.70. You can just give us a call and have a private OSHA and HIPAA status review. Sometimes it's good to see, hey, what's required? What am I missing? Do I need to have a really big program? Do I just need something smaller like the pandemic plan? So, John, I want to thank you as always for letting me speak with Fortune members. I want you to know that if you need a resource, my team and I are here and dedicated to offices, dental offices' success through this delicate time. Any other questions before we depart?
Yeah, we've got a couple that have come in, and then I received a text from a client of mine. I wanted to share some information that was recently released from the CDC.
Okay.
Which ties into the first question or the first statement here. And it says guidance from the CDC seems to be at odds with OSHA recommendations. CDC is recommending preserving PPE, and this is a little bit confusing. What guidance would you provide there?
Well, preserving PPE, but then also I'm finding that when I speak with OSHA inspectors, that they want a good faith effort. They're looking for written protocols, and they're looking to make sure that people aren't, being reckless. But then also as a practice owner, I think what you have to realize is all eyes will be on you, the practice owner. So if you have employees who get uncomfortable, there's that whistleblowers protection law where I've had 5 reports of not proper PPE over this break. You're already under enough stress. I would hate to see that you have more stress. I think going through some of these basics with your team and then deciding as a team, the cloth covering, I think, that makes a lot of sense. Just knowing the proper laws is going to be important. Right now we're at a different time. I'm only delivering you information as a trainer from a trainer standpoint in studying this area, but we're in a gray transition area. As we go 3 months from now and even 6 months from now, I think we'll have clearer answers. So as we put your plans together, do your best, and please do reach out to me if I can provide any more clarification. But I see what CDC is saying for those frontline personnel, sometimes in hospitals, is a little bit different than when we're in an aerosol procedure. So what I'm studying is based on CDC, OSHA, and ADA in an aerosol environment that would be a bioaerosol. A little different sometimes than what's going on those front lines in the hospitals, right?
Gotcha. And then let's see here. And again, this is coming directly from the CDC. This does not appear to be dental specific. And so may or may not take into account an aerosol environment, but it says to minimize the number of individuals who need to use respiratory protection through the preferred use or preferential use of engineering and administrative controls, which would be staggering your schedule, lengthening appointment times, foggers, dry shield, isolate, external dental air vacuums, pre-screening patients before appointments, et cetera. Those are your administrative controls to supplement your infection control procedures. Use alternatives to N95 respirators, other classes of filtering, face piece respirators, elastomeric half mask or full face piece, air purifying respirators, powered air purifiers, purifying respirators where feasible. So look for alternatives to N95. Implement best practices allowing extended use and or limited reuse of N95 respirators where acceptable. So I guess according to the CDC, it would be okay to do something along the lines of covering an N95 with a cloth mask, but may not necessarily be appropriate in a dental environment where aerosol is being produced.
I don't think there's anything really bad about that, but definitely that's the distinction is the ADA will help you to go down the guidelines for controlling aerosols.
Prioritize the use of N95 respirators for those personnel at the highest risk of contracting or experiencing complication of infection. Obviously, we saw the study that came out that said dental hygienists and dentists are way at the top of the list on risk of exposure due to aerosol production. If extending the use of face masks, the following steps should be taken to reduce contact transmission after wearing. Discard N95s. Discard N95 respirators following use during aerosol generating procedures. So there's the aerosol component. So what this says is if you're using N95 and it's an aerosol producing procedure, you have to discard that mask following that procedure. This is according to the CDC. That's the way I read it. Verbatim, you can draw your own conclusion, but what it says is discard N95 respirators following use during aerosol generating, which is the vast majority of dental procedures, which would not include a prophy with a hand scaler, but would include a filling prep, right? Discard N95 respirators contaminated with blood, respiratory or nasal secretions, or other bodily fluids. That's a pretty obvious one. Discard N95 respirators following close contact with or exit from the care area of any patient co-infected with an infectious disease requiring contact precautions. And then lastly, I can't read all of it. Consider the use of cleanable face shield over N95 respirator. Okay. So option, I think you said earlier,
Option B.
The preferred option.
Yeah, I think it's easy, but you have more risk if you have an exposure. They want you to self-quarantine. It's recommended.
Yeah.
Doctors have to take it in and decide.
Yeah, and the question that just came in, it says, what if you use a dry shield? Again, all of this is going to revert to your professional judgment. So the CDC, and I'm assuming OSHA's recommendation either does not specifically say if you're using dry shield, then you don't have to do this or you don't have to do that.
No, they don't.
They do this, and dependent upon the level of PPE that you have available, supplement that with other infection control procedures like the use of dry shield. So dry shield would be an elevated step that you're taking above and beyond what is required, which is absolutely recommended. Let's see. In the foggers, Willie mentioned the fogger again, specs and where to purchase. You may have some sources there, but I mean, you can get foggers from any pest control company. You can buy them on Amazon. I know Rick Downs, if you visit www.sleeprd.net, that's Rick Downs' website, and he's got a full, I think you can buy little components of it, of the infection control package, a la carte, or you can buy the whole office disinfection program. And it includes the compounds that you mix with electrolyzed water to create hypochlorous acid. That compound can be used to disinfect work surfaces. It can also be used in foggers to fog rooms, fog PPE. So yeah, you just either go to Google and type in, disinfectant fogger, and they've got a variety of different ones. You've got some that have like a hose and a handle where you spray like this, and you've got others that kind of look like those, what are they called? Essential oil towers that spray stuff. I've got one sitting right there that I bought from one of the ladies that's on this call. So it just sprays the essential oil mist up in the air. There are foggers that do that too, that you would basically just set in an operatory and it would just fog the whole operatory. Let's see here. And what chemical to use? We'll ask Jill. If you ask me, I'm going to say hypochlorous acid. That's been the number one most recommended compound from our corporate office and from the other sources that I've collaborated with on this particular subject.
I think because it has not a lot of toxicity, it seems like it's almost created from some natural components. So
it can get in the eyes, it can get in the mouth. There's no bodily harm, but it is, from what I've seen, is the most effective compound they found. Next to, I guess it would be hydrochloroquine as a remedy or a treatment. Have heard that is corrosive to stainless ammonia. Man, that's so far above my pay grade. That's way outside of my realm of expertise. But if that's what you heard it from somebody that's probably a lot smarter than I am. Can you use ammonia? I have no idea.
You know, the only thing with ammonia is you know, the smell can be asphyxiating. So, you know, and that's why we haven't used those compounds really in the dental office. The ones that are not from a fogging standpoint, but from a disinfectant standpoint, the dental advisor did a great study about 2 years ago. Dr. John Molinari did it. And what came out as most effective, least toxic was the Cavicide, Cavawipes, and Cycam's Optum. So if it's for surface disinfectant, but I think what you're saying in the foggers is the hypochlorous acid. And you have to, there's going to be gives and takes with all this, right? For the next 2 years, we're going to keep figuring it out.
Yeah. Okay, guys. Any other questions? Let's get them answered before we let Jill go.
Got any coming in there, John?
I don't see any more coming in. So
all right. Well, I want to thank y'all so much. And I want to wish everyone health and success and return back to work being proactive with a lot of your OSHA and COVID requirements. And if my team and I can help you, please just call, go on our website, and we're here. Okay. Thanks a lot, John. I'll see you again.
Well,
all right.
Thank you so much for joining us today. And
my pleasure.
Again, this has been recorded. I will make it available on YouTube, and I'll send an email out to everybody following with a link to the YouTube channel where you can watch it there, let your staff watch it. Please don't hesitate to reach out to us if you got any questions. And then obviously you've got Jill's contact information. So if you need forms, you know, if you need the patient or the employee consent form that's coming back to work, or pre-screening forms for patients or employees, Jill will have copies of those, correct?
Mm-hmm, absolutely.
Fantastic. Guys, thanks so much for joining us today. And
take care.
Hope you all have a great rest of your day.
Be safe. Bye-bye. Thanks. Thanks, John.
Yes, ma'am.